All right, so today we're talking about immunity, okay? And this is how your body defends against different pathogens. And we'll be talking about what the immune system is made up of, okay? There's physical barriers there, and there's physiological processes that are going to take place. So some of those physical barriers are going to be things like your skin, that's your biggest line of defense, right? Your tears, your mucus, all these things will help. There's certain enzymes that the body's going to produce, and all these things are going to help your body fight against infection or disease processes. Unlike any other body system, this is not an organ system, but it's a collective term for different defensive cells and mechanisms that are going to work in your body. Okay. So your first line of defense is your physical and chemical barriers like your skin, your mucous membranes, your tears, your saliva. These can all prevent pathogens or bacteria from entering the body. Will they stop everything? No, and not always. So a lot of it's going to depend on your state of health, your level of exposure, how viral or how strong, how virulent or how strong that the item is or the bacteria, the disease is that's trying to attack your body. Your second line of defense is a non-specific response, and you have to know this, okay? So second line of defense is going to be that phagocytosis and that inflammation. So it's a non-specific response to any pathogen that's trying to get in the body, okay? And it will initiate the macrophages, the neutrophils, the natural killer cells, and those will come like a big army and try to destroy those pathogens. And sometimes because of that, we'll see things like fever and inflammation in the body. The third line of defense is going to be a specific response to a particular pathogen, and it involves production of antibodies, activation of T and B lymphocytes. Now, your B lymphocytes, those are your plasma cells. They are going to make those antibodies, and they do that in the bone marrow. Also, something you're going to have to know. We call that humoral immunity. Your T cells, they come from your thymus. That's where they're matured at. So you start making T cells when you're a baby, and you'll make them all the way up until you're about 14. And then you'll have enough of them stored in your thymus where they can mature and be activated whenever they need to in response to something in the body. The three lines of defense of the immune system all work together, and they try to protect you against specific things in the body. So again, your non-specific response, examples of that are going to be phagocytosis and inflammation, and your specific response, which is going to cause the production of specific antibodies to go out and try to remove or tag those foreign substances for destruction. All right, and the non-specific immune response, okay, this picture is just showing you that some injury occurs or some bacteria. So you see on that picture there on the top, those pathogens entering the body. So the person has a cut or some port of entry, and the pathogens are entering the body. As a result, your mast cells detect that injury, okay? And that starts the release of the histamine. That histamine is going to release that in or initiate that inflammatory response. Now we know histamine is what? How's histamine going to help here? What does it do?
Pain response?
Okay, well, it could help initiate. So the mast cells are, or that little trigger there is also going to help initiate the release of bradykinin. Okay, bradykinin would initiate that pain response. What does histamine do? Come on, where's my night, people? You know this. We talked about it. What does it cause?
It does
It increased the flow.
vasodilation.
Oh
Okay,
shit.
it increases the flow through vasodilation, right?
Yes.
Mhm.
Okay, so all that white blood cell, red blood cell, blood, all that stuff is going to come to the site because that histamine is going to help to vasodilate the area to make the capillaries more permeable so more things can pass through. Okay. So now we'll have those phagocytes and other immune cells that can come in and try to fight against those pathogens. We'll also have an increase in blood to the area. So that's what's going to cause that swelling, that redness. It's going to become warm. It's going to become painful. All right. So this is part of your second line of defense, the non-specific response. We have this pathogen that enters the body, the macrophages, the natural killer cells, the monocytes, the neutrophils, all act as phagocytes. All right. So they'll destroy the pathogens. The body is going to respond with things like inflammation, fever, that histamine is released. Complement proteins are going to be there. Okay. These are all part of the non-specific immune response. And then that phagocytosis that we talked about is going to occur because all these cells are here now that can do that. And we already talked about the inflammatory response. There are cytotoxic T cells, helper T cells, and B cells. These are all called what? What are these called? What type of cells are these?
The killer cells.
They're called lymphocytes. Okay. Lymphocytes means what? What kind of cells are lymphocytes?
Are they white blood cells?
Yes, white blood cells. Okay. So they're going to help trigger a specific immune response. And together, those cells, the cytotoxic T cells, the helper T cells, and the B cells will either generate a humoral or a cell mediated response. Whenever there's a specific immune response in the body, we're talking about a response against a specific antigen. And that is your third line of defense.
Sorry, the third line is the specific response?
Yes.
Okay.
All right. So there's a lot of different cells. They all have different roles and functions, and they help prevent the body from being infected through physical and chemical barriers. Again, those physical and chemical barriers are things like the skin, which is physical. Chemical would be things like the acid in your stomach, enzymes that are in different cells, and the immune system can directly destroy anything through T cells. T cells are matured where?
Thymus.
In the
In the
Thymus.
thymus. Okay. Then you have neutrophils. Neutrophils will kill bacteria and fungi. They're the most abundant that's going to be there. Then you have eosinophils. Now, most of the time when we see eosinophils, it's going to be in response to some sort of allergic reaction when they're asking you about it, okay? But they also can kill parasite or cancerous cells. The lymphocytes can attack viruses and they help with antibody production. Mast cells and natural killer cells will invade bacterial infections and tumors. Now, your plasma cells make antibodies. And I said those are what kind of cells?
B cells.
B cells. And where does this happen at?
The bone marrow, is it?
In the bone marrow. Okay. And that is part of what type of immunity?
Wait, plasma cells is made from B cells?
Yes.
Okay.
And that's what type of immunity?
Is it the third line?
Third line. Humoral
So
immunity.
it is your specific defense, but it's called humoral immunity. Okay. And it's B cells, and humoral to me means funny, right? Humor is funny. So it be funny. It be humoral. That's how I remember. Humoral immunity is B cells. It be funny. Okay, so those B cells mature in the bone marrow, and they become plasma cells that make those antibodies. You also need to know the structures of the lymph system, because remember, the lymph system is part of your immune system or your immune response. So I talked about this a little bit because I talked about how the lymph system brings extra fluid from the interstitial system back into the vena cava. It also will survey and look for bacteria and things in the system that don't belong there. It also brings protein back, right? Like that albumin. What's albumin responsible for?
Oh, wound healing.
What's albumin responsible for, people?
Water.
Like a water
Okay,
magnet.
you're thinking water magnets. And why do I call it a water magnet? What does it do?
It's pulling
Pulling fluid where?
back into the cell.
Okay,
Into the blood vessels.
back into that that venous end there, right? That's maintaining what type of pressure there?
Osmotic.
Osmotic pressure, okay? Whatever's left over will be in that interstitial area. So that lymph system is going to bring that extra fluid back that doesn't get pulled back through that osmotic pressure, okay? You have lymph nodes, your spleen. Spleen is huge. If you don't have a spleen, that's going to be a problem for you with immunity. Okay. Someone without a spleen, they have a 1 degree temperature change. You better be notifying that doctor unless you have a protocol in place, because they have no way to fight. Okay. Tonsils, that's going to catch anything coming into the mouth. Intestinal lymph tissue. So you'll hear when we start talking about the intestines and digestive about these pyre patches that's in the lymph system that help with bacteria and stuff in there. And then lymphatic circulation, which is what we're talking about. And then your immune cells, your lymphocytes, and your macrophages. These provide the mechanism to identify and remove foreign material. Now, tissues that are involved in immune cell production and development include the bone marrow and the thymus. The immune cells originate in the bone marrow. The bone marrow and the thymus also help the cells mature. So during fetal development, the thymus will program the immune system to ignore self-antigens. When the body doesn't ignore self-antigens, what happens? What's happening?
What's the question?
If the body is not ignoring self-antigens, what is happening?
The body attacks.
The autoimmune.
Okay, good. The body attacks itself, and usually they'll develop some sort of, or they have some sort of autoimmune disorder. All right, chemical mediators are also there, and we talked about some of those, histamines and interleukins. So interleukins, they help with viruses in the body, okay, and they help with communication. So just basically your structures of the immune system that you should be familiar with: the thymus, which is going to produce those T cells. Anytime an antigen or foreign substance enters the body, those T cells are already circulating. Okay, so they're going to try to attack there. The bone marrow, this is the source of your stem cells, your leukocytes, and where your B lymphocytes mature. It also helps make your red blood cells, your white blood cells, your platelets. The white blood cells are key for immunity, and they're classified into neutrophils, eosinophils, basophils, monocytes, and lymphocytes. So remember, I was talking yesterday in class and I said, never let monkeys eat bananas. That's my little key that tells me my level of white blood cells in the body. So never stands for neutrophils, and that's the most abundant. Um, lymphocytes are next, and then monkeys stands for monocytes. Eosinophils stands for eat, and basophil stands for bananas. Never let monkeys eat bananas. That's really how the cells are organized in your body, with neutrophils being the most abundant. And neutrophils are always going to be the ones that are going to come first to that site of infection. The basophils are going to help with that histamine release. Your monocytes are going to turn into macrophages, and those can become part of the phagocytosis process. But macrophages can also help present antigens and mark them for destruction. So it can, inside that macrophage, it can present part of that antigen so that when the antibodies are released, it knows where to go to destroy. It knows where to direct the cells to go to destroy. Again, B cells are another type of immune cell produced and matured in the bone marrow. B cells have antibodies on the surface, and they can act against certain antigens. Your lymph tissue and your organs, there's a lot of lymphocytes there. This helps filter the fluid, remove foreign material, and initiate the immune response. Your lymph nodes, these filter the lymph from foreign bodies and produce lymphocytes to attack anything that's foreign there. Tonsils already talked about. They prevent stuff from entering the lungs. So when it goes on your fork and gets caught, or it comes in your mouth and gets caught on the tonsil, that's something that might have traveled to your lungs. Your skin, you always know that's your first barrier, your first defense. And there are immune cells in the skin called Langerhans cells. And then the spleen, okay, this helps get rid of old or damaged red blood cells. It stores and filters blood, and it makes white blood cells to help protect you from infection. All right, so in the body, you have antigens, you have self-antigens. Now, your body has something called tolerance, and that tolerance is supposed to help you ignore any self cells. Antigens or foreign substances are unique in everybody except in identical twins. Okay? Your human cell antigens are unique in everybody. That's your HLA. The HLA proteins, those are unique in everybody unless you're an identical twin, then they're the same. They're composed of these proteins, okay, and they activate the immune system in order to produce those antibodies whenever an antigen or something enters the body. Again, the specific antibodies are produced by what? What produces the antibodies? What
B
cell
lymphocyte.
produces the antibodies?
Oh, B
Humoral.
cells.
The B cells. So antigens representing themselves are on your plasma membranes, and they're coded by genes that you got from your parents. And this coding on these genes on these cells or these plasma membranes are called major histocompatibility complex, and they abbreviate it with MHC, and it usually falls on chromosome 6. Again, someone's major histocompatibility complex is not going to be like anyone else's unless you're what?
A twin, identical then.
An identical twin. Okay. So one of the main steps of immunity is antigen recognition by the immune cells so that they're able to produce that specific response. The B cells are able to recognize the antigen without any help. T cells can only recognize antigens that are presented to them that are attached to a specific molecule on the cell surface. The major histocompatibility complex has an essential role in activating and regulating the immune response in the cell communication so that the cells are able to communicate each other. This major histocompatibility complex helps detect changes in the cell that's altered by some virus or some cancerous change, and it tells the immune system that that change has occurred and that something's going on in the body. The major histocompatibility complex is also referred to as HLA, or human leukocyte antigen. The antigens are also used to provide a match for tissue transplant. So whenever we want to give somebody a new organ, the first thing we have to do is make sure that they match, right? You'll hear people saying, I need a kidney, but there's no organ donor that matches what I have in my body. Why is that a problem?
Organ rejection.
Yes. So if we were just to give somebody, if I take a kidney out of you and give it to somebody else, unless you're compatible with that person, that's going to cause the kidney to destroy that area, okay, or that organ. So the organ's not going to be any good. And of course, that would be a waste of organs, right? Because now it's going to damage the organ and the person wouldn't be able to use that. So we always want to make sure if we're giving somebody, and this is any kind of transplant, by the way, doesn't necessarily have to be like a liver or kidney. It can be things like skin. So if it's too close, if it's not close enough, if it's too close, it should take. If it's really close, it should take. But if it's not close enough, then what would happen is the body would start to attack it and destroy it. Now, most antigens that come into the body are exogenous. What's that mean? What's exogenous mean?
Substance that came from the environment.
So it comes from the outside. Yes, comes from the outside, not the inside of the body. These antigens are chemical markers that will be located throughout the body. Okay. And they identify cells, and then they induce an immune response on part of the host organism. Sometimes the antigens can be part of the host itself. So that would be an autoimmune. These are the major histocompatibility complex antigens, also called HLA, that are genetically determined. Major histocompatibility complex antigens are typically tolerated by the body's immune system, whereas The foreign ones, or the ones that come mostly from the outside, are not recognized. And so your body is going to mount some sort of immune response whenever they're introduced to the body. Macrophages are critical in the immune response. They come from monocytes. They present throughout the body, and they're present in places like the liver, the lungs, and the lymph nodes. They're large cells. They intercept and they engulf foreign material, and then they process and display the antigen from the foreign material onto their cell membrane. And that starts the immune response. Okay, so the lymphocytes will respond to that display and they'll try to attack it or destroy it. Macrophages will secrete chemicals like monokines and interleukins. These all activate other lymphocytes in the inflammatory process, and this will help mount a secondary response. The primary cell in the immune response is lymphocyte, one of the leukocytes or white blood cells that are produced by the bone marrow. Immunocompetent cells are mature lymphocytes, and these have a special function. They're able to recognize and react with antigens in the body. Two groups of lymphocytes are B lymphocytes and T lymphocytes, and they determine the type of immunity that would be initiated, either cell-mediated, which is what type of cell?
T cell.
Or humoral, which is
B cell.
B cell. Okay? Your T lymphocytes come from your stem cells, and they're in the bone marrow in reserve, and then they travel to the thymus for differentiation and development. So they're going to mature in the thymus. Okay? T cells. Cell-mediated immunity begins when the T lymphocytes recognize an antigen on the surface of a target cell, and they directly go to that antigen and destroy it. Specially programmed T cells will reproduce an army to battle the invader. They also can activate other T and B lymphocytes. T cells are mostly effective against virus-infected cells, fungal and protozoal infections, cancer cells, and foreign cells like transplants. There are a number of T cells marked by different surface receptors, each of which has a special function in the immune response. Cytotoxic CD8 positive T killer cells destroy the target cell, binding to the antigen, then releasing damaging enzymes or chemicals. These monokines and lymphokines that are released destroy the foreign cell membranes. They cause inflammatory response in the body, attract macrophages to the site, and stimulate the growth of more lymphocytes and stimulate hematopoiesis. Phagocytic cells come along and clean up the debris. Helper CD4 positive T cells promote the immune response. The memory T cells remain in the lymph nodes for years, and they can come out and activate the response again if the same invader returns. Two subgroups of T cells have gained importance as markers in patients with AIDS. T helper cells have CD4 molecules as receptors on the cell, and killer T cells have CD8 molecules. These receptors are important in T cell activation. T helper cells have CD4 molecules, and killer T cells have CD8 molecules. Again, these are important in T cell activation. The CD8 positive killer killer cells are cytotoxic. CD positive T cells regulate all cells in the immune system. All right, so CD4 positive T cells, that's the T cells that we look at when we look at somebody with AIDS. When those plummet really low, then you no longer have immunity. And in AIDS, these are the primary cells that are attacked. So this is why people with AIDS have no immune system, because those helper T cells, those CD4 cells are being destroyed. And that is your primary immune system. B and T lymphocytes, macrophages, and natural killer cells help secrete the messenger cytokines. Now, we talked about cytokines in chapter 6, I think it was. Okay. And I was talking about how the cytokines produce the response in your body. Okay. And so we were talking about how people with COVID-19, some of them died from a cytokine storm because they trigger the immune response. Okay. And sometimes the immune response that they triggered in COVID was really strong. And it was an aggressive or overactive cytokine initiation. And so these people could actually die from a cytokine storm. All right. So these cytokine messengers help initiate the immune response. And they're going to send out different signals to different cells to do things as part of that immune response. HIV destroys CD4 positive cells. This cripples the entire immune system. The ratio of CD4 to CD8 positive T cells is normally 2-to-1. This is closely monitored in people that are infected with HIV, all right, so that we know what their immune status is. Once those T cells drop below a certain level, they're automatically going to be diagnosed with AIDS at that point. And what that really means is they have no more ability to fight infection, or a very limited ability, I should say. And that's why they develop, usually they won't die from the AIDS or the HIV itself. They'll develop an infection, what we call an opportunistic infection. Most of the time it's going to be pneumonia, like your Carini pneumonia or your Giravici pneumonia. And that's what they end up dying from.
Question. So does this mean like the common cold like can take them out?
So if that cold turned into the pneumonia, yes.
Okay.
A common cold by itself typically wouldn't. They would develop that opportunistic infection from the cold itself. So maybe the mucus and stuff developing in the body, the body's not quite able to fight there. So it gives opportunity now for them to develop that pneumonia, okay? And that pneumonia is typically what takes them out, because now the infection has spread into the lungs. You're not going to see these types of pneumonias or these types of infections in people that are not immunocompromised. Somebody else had a question?
When we say differentiation, like that, does that mean it's still processing and then they mature after that?
So remember, differentiation is the way they grow and change. So when they're in that plasma, they're still immature. Those T cells have to go into the thymus to mature so the body could actually use them.
Okay, thank you.
All right, so B cells or B lymphocytes, these are responsible for humoral immunity. So that's why I say humoral immunity, B, funny. All right, it produces those antibodies. The B cells mature in the bone marrow, and then they go to the spleen and the lymphoid tissue. And after exposure to antigens with the help of the T lymphocytes, The B cells become antibody-producing plasma cells. Natural killer cells are lymphocytes distinct from the T and B lymphocytes. So natural killer cells are not the same as T and B lymphocytes. They can destroy without any exposure or any sensitization. And they'll typically try to attack tumor cells or cells that are infected with a virus. You have to be exposed to a specific foreign antigen and develop immunity to it before this defense is effective. Immune responses that occur after the first induction of antigen are more rapid and more intense. So we're talking about your specific response here, okay? Usually you'll have some sort of exposure to the antigen first, and you'll have a little response. Then you'll have a second exposure and you'll have this major response to it. Destroying foreign material by non-specific defenses such as phagocytosis and inflammatory response helps remove foreign material. The immune system can also prepare injured tissue for healing. So that's the point of your non-specific response. It prepares that area, it kind of walls it off, and hopefully keeps that infection from spreading. Now, you have a number of chemical mediators like histamine and cytokines. These are involved in your immune reaction, and they have a lot of different functions. They can signal certain cells, okay, or they can cause damage. Unique antigens, often proteins of a person's cell, that person's immune system can distinguish from non-self or foreign and detect unknown material. Normally, the immune system would ignore self cells. This is called tolerance. I say that again because they might ask you about tolerance. So tolerance is the ability of the immune system to ignore the self cells. When the immune system recognizes a specific non-self antigen as foreign, it will develop a specific response to that particular antigen and store that response in its memory. It's similar to a surveillance system that's warning the body of an attack and mobilization of an army for defense. For example, lymph tissue in the pharynx, such as the tonsils and the adenoids, can capture antigens in material that's inhaled, ingested, and process the immune response. A cytokine storm can be triggered by certain infections or non-infectious agents, but especially by viral infections like H1N1 influenza and SARS-CoV-1, the most recently reported in infections with SARS-CoV-19. Cytokine storm, also referred to as hypercytokinemia, is a physiological reaction by the immune system that involves an uncontrolled and excessive release of cytokines. The most common clinical condition associated with this is acute respiratory distress syndrome. So that means these people might even end up on a ventilator. All right, types of immunity. So we have humoral immunity where antibodies are produced, and that is what type of cell? What type of cell for humoral?
B cell.
B.
B. How about cell mediated?
T cell.
Okay. The lymphocytes here are programmed to attack non-self cells to protect the body. All right, so in humoral immunity, the host defenses are mediated by antibodies present. Cellular mediated, the host defenses are mediated by antigen-specific T cells. So here's some of your antibodies, also called immunoglobulins or gamma globulins. Okay. These antibodies do not actually destroy the foreign antigens they become attached to, but they label them for destruction. Your body will create new antibodies whenever it's infected or exposed to a new antigen. If the same antigen infects you a second time, your body can quickly make copies of the corresponding antibody to destroy it. These brave soldiers only live for a few weeks, so it's a good thing there's a lot of them. So now, when you go and get your blood drawn, what do they draw that tells you about your risk?
Titers.
Titers, right? So when you come to school, they're like, no, this isn't good enough. Yes, I know you got the vaccine, but the vaccine doesn't show me whether you're at risk or not. And they're actually trying to protect you here. Because the last thing you want to do is get some crap from one of your patients and bring it home to your family. So your body creates new antibodies when it's infected with a new antigen. And again, if the same antigen affects you again, your body's going to make multiple copies. Each antibody is specific for only one antigen. B cells can produce millions of different antibodies. There's 5 classes of human antibodies designed by letter names. So IgG, IgA, IgM, IgD, and IgE. Antibodies can also neutralize viruses. They can attach to the virus and keep it from being able to get into the cell. The virus is not able to reproduce outside the cell. So if you remember from infection, one of the things we talked about there is the virus needs what in order for it to reproduce?
A host.
A host. What kind of host?
They need oxygen.
Susceptible.
A human. They need a human host. Okay? So they have to be able to get into the cell of that human host in order to replicate it. If the antibody is able to neutralize it and prevent it from entering the cell, then it won't be able to reproduce. Viruses cannot reproduce outside the cell, and those coated with antibodies will be phagocytized by the macrophages. So remember, it's being tagged for destruction. The macrophages will be able to recognize that and phagocytize it. So IgG, also known as gamma globulin, is the main immunoglobulin in blood, lymph, cerebral spinal fluid, and perineal fluid. It can cross the placental barrier and provide protection to the fetus and newborn. So this is IgG, crosses the barrier, provides protection to the fetus and the newborn. IgM is made by B cells, and it's the first class of antibody in response to a new infection. All other classes are formed later. IgA is found in tears, saliva, mucous membranes, and in colostrum. What is colostrum?
Breast milk.
The first breast milk. and
breast
first-
milk.
Yep, it's the first breast milk. So with the first breast milk, besides the IgG that mom gives the baby, okay, the baby's going to have some IgA. IgE is a vital part of the immune system. This is responsible for type 1 hypersensitivity reactions in responses to allergies. You better know that. IgE antibodies help release inflammatory mediators like histamine. This is what causes the symptoms that we see in things like anaphylaxis or allergic rhinitis. So you might see a runny nose, swollen, itchy eyes, a rash, or full anaphylaxis, depending on how bad the response is. It's an allergic response, so it can be mild or it can be severe. Anaphylaxis would be severe. High levels are seen on an IgE test. So whenever there's an allergic reaction in the body or a parasitic infection in the body, we're going to see a lot of IgE. IgD is mostly attached to B cells and it can activate the B cells. This has got a lot of stuff on it, okay? So, you want to have an idea about some of the things on here. So you should know what an antigen is, okay? An antigen stimulates the immune response. It's a foreign substance. The antibody. This is a protein that we produce anytime antigens enter the body. Autoantibodies. These are going to protect us against the self antigen. So if someone has an autoimmune disorder, okay, these autoantibodies are going to be produced and they're going to attack the body's tissue. Thymus. Okay, what grows in the thymus?
A T cell.
T cells. They'll mature there, okay? Lymph tissue, your lymph system, this is all part of your immune response. It's not only going to remove and survey your system, but it's going to help you get rid of some of that bacterial and stuff. The bone marrow, this is where the B lymphocytes mature. Your stem cells are produced from there. Your white blood cells. Neutrophils, again, those are going to be part of the non-specific defense system. They'll be active whenever there's inflammation in the body. They're the first white blood cells for phagocytosis. Basophils, also white blood cells. These help release histamine. Eosinophils, allergic reactions. Monocytes, these are going to become macrophages. And macrophages do phagocytosis, and they help present the antigens to the body for the immune response. Mast cells, these are going to release histamine. B lymphocytes, that's your humoral immunity. And they produce those antibody cells, okay? Or plasma B cells, we call them. Plasma cells develop from the B lymphocytes, and those B lymphocytes, once they become plasma cells, then they secrete the antibodies. T cells, those are cell-mediated immunity. Cytotoxic or killer T cells. All right, you guys know those are for antigens, cancer cells, viruses. Helper T cells, that is your basic immune response. Histamine, you should know. Look at this one for histamine, okay? Released from the mast cells and basophils in allergic reactions, vasodilation. That's the main thing you want to know. It causes vasodilation, increased vascular permeability. So this means all things can move through that vessel now. Why is that important? Because now those blood cells, those white blood cells, the blood flow, all that can come to the area of the injury. Kinnins, bradykinin. Pain, think mostly there. But this can also help with vasodilation and also opening up the vessel, causing more permeability to let things through. Cytokines, think of those as your chemical messengers. Okay, your lymphokines, your monokines, your interferons, your interleukins. They also help stimulate activation and they promote the release of B and T cells. They help communicate between the cells. We're going to see these whenever there's inflammation, fever in the body, or an increase in those white blood cells called leukocytosis. All right, so that's most of the ones in there. Again, I put a little bit more description here for you. You should have this slide, okay? So go in and look at it. It's just kind of telling you what everything does. You want to really understand it.
Sorry, Miss. Can you please go back to that slide?
You guys should have this in your slides. I believe it's in there.
Okay, thank you.
Remember interferons, okay? Those are ones I want you to remember. Those are secreted by virus-infected cells. So if they ask you about interferons, think about viruses. Your complement system is a group of inactive proteins that are in your circulation system. They're activated whenever certain chemical mediators are released, and these promote inflammation, chemostasis. Now, chemostasis is when the body is pulling certain things to the area, like certain white blood cells or certain cells that it needs to do something. And it needs those cells in the area, so chemostasis attracts them to that area, okay? And then phagocytosis, you know, is when it engulfs or breaks stuff down. The complement system is mostly activated during an immune reaction with IgG or IgM. Think about an army trying to protect and defend a certain territory from an enemy. Once the enemy is spotted in that territory, the army will buckle up and eliminate the enemy. The complement system is similar. A lot of proteins in the body will circulate in the blood and the tissue, and they're ready to eliminate anything that comes in and tries to invade that area, any kind of pathogen. Now, the proteins are inactive until they encounter that pathogen. Once they encounter the pathogen, then they become activated. A bacteria or a virus could activate them. The proteins mainly complement the role of the other immune cells, so that's why they're named complement. And the proteins, according to their name at the time of discovery, are labeled by the letter C, and they're named from C1 to C9. Now, you don't have to know what they are. You just have to know what they do. Okay? So these proteins are going to be activated, okay? And they can cause additional cell damage and inflammation if they are activated. There's also chemical mediators like histamine and cytokines that may be involved in the immune response. These chemicals have a variety of functions, like signaling a cellular response, or they could be there to cause some sort of cellular damage. Now, histamine is released from the mast cells and the basophils, especially whenever you have an allergic reaction in the body. Histamine is going to cause vasodilation, increased permeability, edema. It can help in dilation of the blood vessels, stimulate the production and release of relaxants of smooth muscles of the blood vessels. It can also cause the vessels to become leaky, meaning things can leak through them that wouldn't normally leak through them. And that helps with the response there, because now certain white blood cells and more blood flow and things can get through that vessel. When the allergen enters the body a second time, the antibody IgE, I'm sorry, I skipped something here. As allergens enter the body, they're recognized by the IgE antibody present, okay? On the B lymphocyte that's specific for that allergen. That produces that memory plasma cell. Remember, plasma cell is a B cell. So it's a memory B cell, really. The mast cells and the basophil cells contain the receptors for the IgE antibody, and the IgE antibodies will bind there. When the allergen enters the body the second time, then the antibody IgE present on the surface of those mast and basal cells will bind with the allergen, and that will cause degranulation of the basal cells and the mast cells, and that's going to cause release of histamine in the body. The histamine will then produce the allergic reaction. Other chemicals like leukotriene and cytokines are released, which also contributes to that allergic reaction. When histamine is released in the lungs, it will cause wheezing because of inflammation in the airway. In the nose, histamine causes things like nasal secretions, sneezing, and itching. Cytokines, which include lymphokines, monokines, interferons, and interleukins, are produced by macrophages, activated by those T lymphocytes. They help with the growth and the stimulation of the B and T cells and communication. So like if you ever rolled your ankle and it became swollen, or you got a cut that became infected, then you've experienced cytokines being released in your body. Cytokines are called messenger cells because they take a message throughout the body. Once they bind to the cell, they give that message to the cell. And that message might say increase inflammation and pain to that area of the body, like that ankle that you just rolled or sprained. Cytokines are small, non-structural proteins secreted by different cells in the body, and they help regulate inflammatory and immune responses. Cells that secrete cytokines are white blood cells, like lymphocytes and monocytes. Okay, so we talked about all this. Any questions on any of that? You guys know what the self-antigens are. You know what tolerance is, right? What is tolerance? What is tolerance? You got to know this. Who knows it?
The ability of the immune system to ignore something.
Right. The ability of the immune system to ignore. And anything that is not a self-antigen, the body should respond to. Okay? And it's going to store memory cells, those memory B cells, for future encounters. Okay? This is just telling you about some of the barriers in the body and how they protect you. We talked about most of that already. Okay, this is diagnostic tests, which you don't need to know. But the next you need to know. Okay, so you need to know the types of immunity. So you have natural immunity. Okay, you only have natural immunity for human being. Okay, typically we're not susceptible to infections that other animals develop. There are a few exceptions to that rule, but for the most part, we're susceptible only to certain infections that other people get. Innate immunity is gene specific. It can be related to ethnicity. So you might have an increased susceptibility of getting something. For example, indigenous people from North America are more susceptible to tuberculosis. Active immunity develops when your body develops antibodies or T cells in response to an antigen introduced in the body. And it takes a few weeks for it to occur, but it usually lasts for almost forever, really, for years, okay? Because of the memory that the T and the B cells provide there. You have to know the difference between primary and secondary response. So in the primary response, the antigen's recognized. It will initiate a response. It takes about 1 to 2 weeks, okay? And then the antibody levels will fall after that point. So they'll rise for a minute and then fall. In a secondary response, when you're exposed to that same antigen again, you'll have a rapid response. You have a higher antibody level than in the primary response. And then years later, your body, if exposed again, can mount that huge response to that exposure. So you have to know the difference between primary and secondary. Your primary immune response is the first line of defense against the pathogen. It's a non-specific response. The response primarily uses phagocytic cells. Secondary response to the pathogen that the body has previously encountered utilizes specific T and B cells, and it's quick and efficient. It uses memory. Antibody titers, we measure the antibodies. So it'll measure your body's response to a exposure. And that's what tells us if you have immunity or not, by your body's response to that exposure. All right, these you have to also know. Active natural immunity. Okay, so active immunity starts when your body develops the antibodies or T cells in response to the antigen introduced. Takes a few weeks. Active natural immunity can be acquired by direct exposure to an antigen. For example, you have an infection and you develop the antibodies. Active artificial immunity develops when a specific antigen is purposely introduced into the body, like a vaccine. It stimulates the production of the antibodies, but you don't get the disease. All right, so this is what vaccines do. So active natural immunity would be like you came home and you're taking care of your kid and your kid has chickenpox. Now you're exposed. Maybe you never had chickenpox because everybody doesn't get chickenpox as a kid. If you're not exposed to it, you won't get it. Your body builds antibodies to it. That would be a natural immunity. And as I just told you, on the primary response, you'll have a low protection here at first because it's a very small response. But your body will remember that response. So if you're exposed again, it should mount this huge defense. Active artificial, we give a weakened toxin to the person, right, in the form of a vaccine. And that stimulates the antibody production, provides immunization. Sometimes people need a booster. Passive natural immunity is very short acting. Okay, this is like the IgG. Remember, IgG can cross the placenta and give immunity to the baby. How about IgA? Baby can get IgA through the breast milk. So this helps with the baby in the first few months of life because the baby's immune system on its own is not fully mature. And then artificial immunity, this would be like if you got bitten by a snake and we had to give you a snake venom. Okay? This would give you, we would inject the antibodies into you. Okay? And that would be, it's called a snake anti-venom. We could do the same thing if you had rabies or if you were at risk for getting rabies. So whenever someone gets bit by a dog, one thing that we want to know is, do they have a rabies record? If they don't, that's a problem. because if the dog is suspected of rabies now, that person is going to have to go through a series of shots. By the way, if they get the rabies, they'll probably die. So we want to protect them from getting those rabies. So you need to know the difference between these four: natural, active, artificial active, natural passive, artificial passive. Also, we have some new rates in this country right now that were previous infections. Okay. And now we did have herd immunity, right? Because when I was a kid, everybody got vaccinated for MMR, smallpox. And now people are not getting vaccinated. That's why we're seeing outbreaks, because people are not vaccinated. Or maybe the vaccination didn't take for some reason. Or people are traveling into an area where they're not vaccinated, and so they're bringing those diseases with them. Now, additional vaccines we continue to do research on are AIDS, malaria, TB. So again, we don't have vaccines for these, but we're looking into potentials. Emerging infections and re-emerging, okay? Again, we're looking at older diseases on the re-emerging, and the emerging infectious disease are newly identified. So right now, this is not a new one, but we just have a new outbreak of Ebola. So that's going on in certain countries right now. Okay. Also, Zika virus from the mosquito. And a lot of people don't even know if a man has that, it stays in his sperm for up to a year. So if you have sex, unprotected sex with him, and you get pregnant, that baby can be affected. Bioterrorism, a lot of countries keep stuff on hand just to fight. Okay, so a lot of countries have smallpox for biochemical warfare if they ever need it. All right, let's talk about tissue and organ transplant rejection. So there's a couple different types of rejection somebody can have: a hyperacute injection, which happens immediately after the transplant, an acute rejection, which can happen several weeks after, or chronic late, which can happen years after or months. Okay, so again, rejection involves a type 4 cell-mediated hypersensitivity reaction and humoral response. It causes inflammation and necrosis, and rejection will eventually destroy the organ. So a lot of times these transplanted organs are going to have to be replaced. The most common transplants are skin, cornea, bone, kidney, lung, heart, and bone marrow. And we're bringing foreign tissue from one person who's the donor into the body of the recipient. And because of that human leukogen antigen, remember that major histocompatibility complex I was talking about, okay? If it's not very close to the person's own makeup or genetic makeup, the body's going to reject it. These are the types of organ transplants. So allograft is from one human to another. Isograft is genetically, so identical twins. Autograft is when we take from one part of our body to another. And xeno would be things like pig or beef or some other sort of substance other than that species. Immunosuppression. Okay, the problem with this is it makes people at risk. So we want to make sure that we put the most everything in place that we can so people don't reject the organ. All right, so we want to make sure the tissue matches closely, and they might have to get some drugs or something. You need to know these four types of reactions in the body. So type 1 is usually IgE. And we usually see this with allergic reactions. Okay. Type 2 we'll typically see with blood transfusions. This is called cytotoxic hypersensitivity. And what happens is, as we start to give the blood to somebody, it's not their blood type, it starts to lyse the cells. This can also happen if mom and baby have different Rh factors. It can happen in hemolytic anemia. Anybody know what the two types of hemolytic anemia are? So they are sickle cell and thalassemia. And then type 3, we have this complex mediated hypersensitivity. So what happens here is these complexes form and it deposits in the tissues and it causes inflammation and a massive response there. So type 3 hypersensitivity reactions we'll usually see in like serum sickness, glomerulonephritis, some of your autoimmune diseases like rheumatoid arthritis or SLE. And then type 4 cell-mediated hypersensitivity. This is what you see like when you wear the gloves. And all of a sudden, underneath your glove, you have contact dermatitis. Or you put a Band-Aid on, and underneath the Band-Aid, you have contact dermatitis. We also can see type 4 when someone rejects like a skin graft. So type 1 is called immediate hypersensitivity because this is your body's response to an antigen, and it usually occurs immediately or within a few minutes of exposure. So I'm highly allergic to bees. As soon as it stings me, this starts. You're eating shellfish, you're allergic. As soon as you bite it. And some people that are so allergic to shellfish, they don't even have to actually eat the shellfish. Let's say somebody made a salad and there was shrimp in the salad, but they only ate the salad part, not the shrimp. If the shrimp touched that salad and they're really allergic, they can still have a reaction. Primary antibody involved in type 1 hypersensitivity is what? You better know this. It's going to be on the test. Type 1 hypersensitivity, what is it?
The development of IgE.
IgE. All right, so you're going to have mast cells, basophils, and histamine. And what does histamine do?
Vasodilation.
Vasodilation. It's also going to be the cause of what? The runny nose, the itching, the rash, the hives. And anaphylaxis can occur, which can cause someone to die, go into shock, have an MI, all things they might ask you about. So again, hay fever, food allergies, atopic dermatitis, asthma, all these things associated. What's going to happen? Histamine release. Histamine's that vasodilator. IgE released. Okay, that's your eosinophils. It can happen if you eat food too. It can cause problems with the GI tract. It can cause problem with the airway. It can cause a problem with your blood vessels. Okay, so when that histamine is released, these are all the things that can happen. Anaphylaxis, this is severe, life-threatening. We'll see a decrease in the blood pressure or hypotension, they might say. Airway obstruction. Severe hypoxia, and causes are going to be latex, if someone's exposed to latex and they're allergic. I just said sting from a bee, nuts, shellfish, and certain drugs. What's it going to look like? I would know this. So hypotension, right? We just talked about. Itching, tingling. They say in the oral cavity. You want to know where we feel it at? Right around the ears. So where the ears and the jaw join, that's where that itching will start, or right on the palms of those hands. Coughing, difficulty breathing, weakness, fainting, panic, because they're losing it there. Hives, loss of consciousness. All right, we already went over this. What's on this slide, I would just tell you to read it, okay? Again, if you don't understand, you better understand it. Signs of anaphylaxis, know them. We don't care about treatment, okay? Type 2, cytotoxic. This is going to be, remember I said blood transfusions are the most common here. So we're going to have destruction, which means the blood cells are going to start to break down there. And that's going to cause things like that itching, that warmth. If mom's negative and the baby's positive, as far as the Rh factor, this can happen. All right, so again, type 2 sensitivity is going to involve IgG or IgM. We'll have damage to the self cells. This is another example of type 2 when the AB and Rh groups react. So it can either be autoimmune, like rheumatic fever, idiopathic thrombocytopenia, so the body is attacking itself. Type 3, hypersensitivity. Here the antigen is combining with the antibody, forming these complexes that are deposited in the tissue. So your book gives the examples of glomerulonephritis, rheumatoid arthritis, serum sickness, which is when the body has this systemic reaction in response to certain medications, like a vaccine or an antitoxin. Your book also mentions farmer's lung. This can cause this, okay, if they inhale some sort of mold from like the straw and stuff. Type 3, again, those complexes are going to be deposited in the tissue. That is the big thing for type 3. And then type 4 is going to be that delayed response, okay? So like with the contact dermatitis, how many of you have that? When you put the glove on, initially you're fine. Then about 4 hours later, or sometimes the next day, what do you see on the back of your hand is this rash or these bumps, and it's only going to be where that latex or where that Band-Aid made contact with the skin. So sometimes if you put a Band-Aid on, like the whole arm's fine, but wherever the Band-Aid was is red, swollen, and bumpy. Your TB test gives you this sort of response. So they shoot the serum under the skin, and then what happens? You get this little bubble, and the bubble can react and either grow or stay the same if it doesn't react. All right, so again, this is just showing you the process. Remember autoimmune disorders? We talked about this quite a bit, but that's when the antibodies go against themselves. So some examples are listed there on the bottom. Hashimoto thyroiditis. So this is where the thyroid actually destroys itself and you end up with hypothyroidism. Systemic lupus erythematosus, rheumatic fever, all of these are diseases where the body destroys itself and attacks its own cells. So this is just showing you the process here, okay? This is the autoimmune process here. All right, some diseases you'll want to know. Come on. SLE. Okay, this is a chronic inflammatory disease. It can affect multiple organs, your heart, your kidneys. These people typically will have this butterfly rash on the face. It's very prominent. You can see it. Okay, it mostly affects young women. The problem is they have these circulating autoantibodies against the DNA. So that is the key factor there that they'll ask you about, those circulating antibodies, autoantibodies. And then they may ask you about the symptoms. So it affects the joints by causing them to become painful and swollen. The skin, again, with that butterfly rash, that's very prominent. The kidneys, they can develop glomerulonephritis from the antigen antibody deposits there. The lungs, the heart, the blood vessels, the central nervous system, the bone marrow. So all that affected. Guys, I am going to continue on and do the skin. So just hang in there. I know some of you might have to go, but I am going to cover it for you. Just want to make sure this is thorough for you so you understand it. All right, SLE, again, look at the top line there. Circulating autoantibodies. That's key. Okay? Those immune complexes in the tissue. That's key. All SLE. These are things specific to this disease. Signs and symptoms, okay, because of the organs being involved. Arthralgia, fatigue. Arthralgia is pain in those joints. They're going to have cardiovascular problems. Immunodeficiency. This is when we have partial or loss of one or more of the immune systems, okay? And this can cause us to be at risk for infection or cancer. It could be acute, short-term, or chronic. If it's a primary deficiency, then there's some sort of failure in the system, maybe in the bone marrow with the production of the stem cells, maybe in the thymus, or maybe the body's not making the proper antibodies. It's usually from a genetic or congenital abnormality, and we usually see it in infants and kids. Examples are inherited X-linked hypogammaglobulinemia, where they have low levels of the gamma globulins, or IgG. Puts them at risk for opportunistic infections that are hard to treat. So they can get infections from normal things like resident flora that's normally in the body. So they can get fungal or candida infections in the mouth known as thrush. Or sometimes they might even get life-threatening infections like that pneumocystis carinii that I talked about. So they'll need some sort of, treatment for this. That's not our concern because we're not doing treatments. AIDS is a chronic infection caused by HIV that destroys those helper T cells. I talked about that, right? So they lose their ability to fight. They lose the immune response. They're more at risk for infections, especially secondary infections and cancer. So one type of cancer that they'll get is Kaposi sarcoma. The virus primarily infects the CD4 positive T helper lymphocytes, causing a decrease in the function and the number of cells. Both of these cells are essential for humoral and cell-mediated immune responses. So that's going to affect their ability to fight any infection. HIV attacks the macrophages and the central nervous system cells. The virus invades and multiplies in the lymph tissue, the lymph nodes, the tonsils, the spleen, and it uses these tissues as a reservoir for continued infection. All right. So with AIDS, we know that the virus is there. Okay. I'm sorry, with HIV, we know that the virus is there, but we're not immunosuppressed yet. Once we start to look at those T helper cells, then we know what that status is. With AIDS, they're going to have symptoms, okay, because they're going to be developing things like those opportunistic infections. So first case of AIDS in 1979 and HIV identified in 1984. We know it's transmitted in body fluids. Let me just go back one slide. We know it's a retrovirus, okay? So it's going to be in the RNA. Major cause of AIDS is HIV-1 in the United States and HIV-2 in Central Africa. And then transmitted, okay, blood, semen, vaginal fluids. What kind of symptoms would we see? Lymphadenopathy, which is swollen lymph nodes, fatigue, weakness, headache, arthralgia, GI effects because of those opportunistic infections, encephalopathy. This is often called AIDS dementia. Okay, so the brain cells are actually infected here, and then they're at risk for secondary infections, which I told you is the main cause of death there. They get those opportunistic infections like that pneumonia. They can also develop other things. We see a lot of TB, as actually TB rates are going up in the United States and worldwide because of HIV. The cancers I talked about, Kaposi sarcoma. I didn't talk about non-Hodgkin's. Okay, the Kaposi sarcoma, they will have purple brown spots in their mouth, and they can have what we call purple spots on the skin. We're also rates of non-Hodgkin's lymphoma are increasing also because of AIDS. You don't care about treatment. All right, let's go to 8. So now we're going to do Ewing, and you are, Ewing HSC 203, Chapter 8 for Patho.
Professor Loach,
Yes?
while you pull that up, what's the difference between HIV-1 and HIV-2? I didn't know there was a 2.
I would have to look at the differences. I don't think there's a lot of difference. I would really have to look them up. Let me see if I can give you just a brief synopsis.
Okay.
So HIV-1 is more aggressive. HIV-2 is less virulent, harder to transmit, and also harder to treat.
Okay, thank you. And then you also said something about C1 to C9 complement cells. You said we should know what they do.
Just know what they do. You don't have to know what the different names and everything are. I haven't seen them ask any questions about that.
Okay, thank you.
So usually also the viral load in someone with HIV-2 will stay low for a long time. If you know anything about HIV, when we treat it, we look at the viral load. And depending on how strong the viral load is, that's what we're going to try to decrease is that viral load. And that will help us prevent the spread of it. So in people with HIV-2, that load remains lower. And so therefore that would contribute to the least amount of spreads there as opposed to HIV-1, where our viral loads are usually high and causes a lot of spread of that disease.
Okay, good to know. Thank you.
All right, so for the skin, what does the skin do? So first of all, it's the largest organ and it's going to help prevent as far as defense whenever it's not broken. So it stops anything from entering the body that we don't want in it, like microorganisms and foreign material. You have sebaceous glands there that produce sebum. That's acidic. It inhibits the bacterial growth. You also have resident flora, and that will deter certain organisms from coming into the body. It also prevents you from losing fluid. It helps maintain your body temperature. It uses two mechanisms to do that: cutaneous vasodilation to increase blood flow out to the peripheral areas and increase secretion and evaporation of sweat. Both of them can cool the body down. Sensory perception by the skin is also a defense mechanism, protecting us against certain environmental hazards. So just a review of the skin, you have two layers, epidermis and underlying dermis. Okay, and then also you have hair follicles and glands there. The epidermis has 5 layers that vary in thickness. There are no blood vessels or nerves in the epidermis. Nutrients and fluids that go into it have to come from the blood vessels in the dermis. The dermis is a thick layer of connective tissue that varies in thickness throughout the body. It's right below the epidermis, and it has your elastic and your collagen fibers. Those help provide flexibility and strength, and they also give support to the nerves and the blood vessels that go through the dermis. There are sensory receptors there that will tell the body when there's pressure or pain or heat or cold. Below the dermis is subcutaneous tissue or hypodermis, and that is where connective tissue, fat cells, macrophages, fibroblasts, blood vessels, nerves, and some of the bases of those appendages, like the hair follicles and the glands, exist. So just a little picture there for you of the different layers.
Are you sharing the screen, please?
We can't see your screen, Miss Lewis.
Okay, good now?
Yeah.
Okay, so that just gives you a little picture of it with the different layers and what they do. There's 5 layers of the epidermis. Keratin is a protein that's found in the skin, hair, and nails. It prevents loss of body fluid through the skin and excess of water from entering into the body. So like when you go swimming, you don't absorb all the fluid that's there in the pool. The amount of melanin or dark pigment will determine skin color. Melanin production depends on multiple genes and environmental factors like exposure to the sun. Dark-skinned people rarely develop skin cancer due to ultraviolet light exposure because they have that increased melanin in the skin, and it actually protects you from the sun rays to a point. Albinism is a congenital disorder where the body doesn't produce enough melanin. So a person with albinism will have white skin and hair, and they don't have the pigment in the iris of the eye. They have to avoid exposure to the sun. Melasma or cholasma are patches of darker skin on the face. You might see those in someone that's pregnant. An additional pigment called carotene will also give a yellow color to the skin. So that's your 5 different layers. I'm not going to go through all those, okay? You should know what they are. That's your A and P. So just review those so you know what they are. I would expect them to ask you more about diseases related to different layers of the skin or burn. You know, like if a burn went to the dermis, the epidermis, or what part of the skin would be infected. If you have something like cellulitis, more than I would expect you to ask them to ask you about this stuff here. But you should be familiar with the layers of the skin. That's your A and P. You have to know it as a nurse. The dermis is the connective tissue that varies in thickness throughout the body. It's below the epidermis, and it has the elastic and collagen fibers. It gives flexibility and strength to the skin. It supports the nerves and the blood vessels going through the dermis and the sensory receptors for pressure, texture, pain, heat, and cold are found here. When they talk about the appendages, they're talking about the accessory structures like the hair follicles, the sweat, the sebaceous glands, and the nails. Okay, so all these are associated with the skin and for different reasons. All right, hair follicles help you collect bacteria and things like that. The glands produce sebum for secretion, and it helps influence the sex hormones. And then your sweat glands, okay, which can help cool your body down. There's 2 different types of sweat glands. Your merocrine or eccrine, these are located all over the body. Your apocrine, which are located in the axilla, the scalp, the face, the external genitalia. And really, when these secrete fluids, the odor is not supposed to be present there. However, because of bacteria action by the normal flora, that will cause people that sweat to develop an odor. So therefore, some people have to wear deodorant, or most people have to wear deodorant, right? Because when the bacteria interacts there with the fluid that's produced, that is what actually causes the odor. Beneath the dermis is the hypodermis. And this is where your connective tissue, fat cells, macrophages, blood vessels, nerves are all located at. Again, another picture just showing you the different areas of the skin, okay? Melanocytes, those are cells of the skin, okay? So you should be familiar with those. You might also want to know, like, you know, where mitosis occurs, where protein synthesis. So if you want to know those things, go through and look at this. You need to know about the flora. So the skin has mixed resident flora on it. And that flora can be different in one area of the body versus another. They like to ask about this, so I would know about it. There are microbes that are under your fingernails. They can cause a problem because when you scratch and it breaks the skin, those microbes can get underneath the skin and cause an infection. You can also develop like yeast infections or opportunistic infections. If there's an injury there, like a burn or some sort of lesion, and your your immune system is compromised in some way. All right. And then the infection can spread, okay, systemically if you have a lesion on the skin, which means it goes from a local infection in your leg to now one throughout your entire body, like MRSA. Okay. MRSA you could be in a locker room or even at work in a healthcare facility. And let's say you cut yourself shaving your legs. Sorry, guys. I don't know if you do this or not, but for the girls, if we cut ourselves shaving our leg, let's say you go to the gym. This is a good example. You go to the gym. Yesterday, you were shaving your legs and you cut yourself. And now you're at the gym and you didn't cover that area. Okay? Because locker rooms is where most MRSA is spread. That's why you should always wear flip-flops in there. Don't share towels with other people, things like that. So this cut, that MRSA can actually enter into that cut. Okay? And then it would become a systemic issue. So that's what it's talking about when it's saying infection spreading systemically from a skin lesion. The skin's prone to damage, okay? And this can be from toxins produced by opportunistic microorganisms like drying of the skin. So sometimes our skin's dry and we develop rashes or damage to it, or we scratch ourselves because we're itching and we just hit it with those fingernails and the skin's so dry, it causes some kind of damage there. Systemic disorders can also affect the skin. The skin ages. It'll lose elasticity. It becomes thin and it loses subcutaneous tissue. If a large area of the skin is damaged, you can lose some of the appendages, like the function to produce sebum or to grow hair. Scar tissue can form on that area, and scar tissue can affect the ability of the joints to move. Skin lesions can be caused by systemic disorders like liver disease, systemic infections like chickenpox, or allergies to certain foods, as well as exposure to any type of toxin. We look at skin lesions, and that can help us make a diagnosis. So we look at the location, the length of time the lesion has been there, any changes that have occurred over time, the physical appearance. So we'll look at the color, if there's any sort of swelling or inflammation there, any sort of exudate, any sort of pain or itching. Sometimes lesions can tell us about certain things. Some lesions are tumors, and they might not be painful or pruritic. So a person might not even notice them unless they're annoying or causing them some kind of problem with what's happening. All right, this is showing you different types of skin lesions. Okay, so a macule is going to be small, flat, but it looks a different color than the skin. And some of you might have these macules. So just look on your body. Do you see an area there that's a dark color? It doesn't look like the rest of the skin, or maybe it's lighter, and it's just a flat area. With a papule, you're going to have an elevation there, but it doesn't have fluid or anything in it. It's just an elevated area. Okay, so macule flat, papule elevated. A nodule is going to be a elevated lesion. It can vary in size. It's usually more firm. And then pustules will usually have pus in them, like a pimple.
So, question, is a nodule or a papule like, say, a mole?
I would say a nodule would be more like a mole than a papule, because a papule is going to be, sometimes you'll have just a small bump on your skin, right? And it has nothing in it. It's just a little tiny bump. Like if you feel around your neck area, a lot of times you'll have those little bumps, but they're not moles.
Okay, thank you.
A mole is a little different because there's a lot of stuff going on with the mole. Like you can't even take a mole off your skin unless you have it surgically removed, because you could bleed out with it. Unlike a wart, right? A wart you can take off your skin and you really won't have any issue. For a couple of days, it'll be a little messy, but then that goes away and it comes back to normal. But moles, you can't do that with. They're a little bit different. And you have to watch moles for changes in color and things like that, because they can indicate cancer. As long as it's just a mole and it stays the way it is for years, then it's probably nothing. All right, some other ones are vesicles. These are what we see in like chickenpox or in shingles. So they're kind of a blister. They'll have fluid in them, but it's not usually a pustule, because pustule has pus in it. These will have like a clear fluid in it. Ulcers. Okay, everybody knows what those are. You've seen them, either pressure ulcers or other types of skin ulcers. Plaque. This is an elevation on the skin. So it's scaly-like. So you'll see this in people that have things like psoriasis. Fissures, this is a crack in the tissue. So you might see this with people that have dry skin or some other sort of issues going on. Again, these just talk them out a little bit more. Okay. Other one I would know is keloid. Okay. Litchification. So why do you want to know that? Litchification, because when they talk about psoriasis versus a couple of other skin issues, these are going to help you tell the difference and might be used when they give a definition. So if they give you a definition with litchification in it, it'll be a specific disease. And the same thing with these plaques. Okay, they'll be associated with one disease versus another. So that's how you tell the difference between the two of them. Keloids, these are scar tissue. Okay, and a lot of times people will have keloids. We'll see this a lot of times in darker skin people. You can have the keloids removed, they can grow back, and it's from an increased level of collagen there. So I also try to put some pictures in here just so you can kind of see the difference in them to help you remember. All right, pruritus, this is usually associated with some sort of allergic response or irritation from something like an insect bite or scabies. Histamine is going to be released in response, and that causes the pruritus or the itching. Scratching that area increases inflammation and can lead to a secondary infection, especially if you break the skin. Those microbes under the fingernails can get in there and cause that infection. So contact dermatitis is the first thing we're going to talk about. This is exposure to an allergen. So usually we'll see this in people that have like latex allergies. Maybe they're allergic to gloves, some sort of cosmetics. And usually it irritates the skin, and it's usually going to be the area right where the item was placed. So if you put the cosmetic on your face, it'll affect that. It's not going to affect the rest of your body. It's just going to happen in that one area. There's no immune response here. It's from direct exposure. Usually once we remove the irritant, the area will calm down and get better. So if you notice on the, well, let's talk about this first, then we'll go to the picture. Sensitization here will occur on first exposure, and this is type 4. Cell-mediated hypersensitivity. All right, the lesion is usually a clue to the allergen because of the way it's going to happen. So you'll see that on the next page. So look, this person had a Band-Aid on there. So he's allergic to latex. The Band-Aid had latex in it. You notice it only marked the area where the Band-Aid was. It didn't mark the rest of the skin. So what we're going to see, if it's allergic dermatitis, it's usually a delayed reaction, type 4 delayed reaction. We're going to see itching there, redness there, edema there, and it's wherever the area was covered. So if you wear gloves, it's usually right on the back of your hand. It usually doesn't affect your fingers. It could with some people, but usually you'll see it in that big surface area right on the back of the hand. If it's a chemical irritation, you'll see edema, erythematous, or red, okay? Pruritic or painful. We don't care about treatment. What is this? What is it, guys?
Hives.
Hives. When do we see this usually?
Allergic reaction.
Yeah, so that's going to be what type of allergic reaction? 1, 2, 3, or 4? Got to know this. Who knows? Where's my Patho superstars? Who knows this?
It's type 1.
Type 1. So if I get stung by a bee, this is happening to me most of the time. All right? And when that starts to happen, you better hope you got an EpiPen and 911. Okay? Because these people are likely going to go into anaphylaxis. The histamines released, it causes the eruption of hard, raised lesions on the skin known as hives. Okay, type 1 hypersensitivity, you got to know it. And what will be released in the body? What antibody? Come on. What antibody is going to be released here? IgG, IgA, IgM, IgE, IgG. What's going to be released?
IgE.
IgE. Okay. So hives, hard, raised, erythematous lesions, very itchy. Usually, it'll start itching again around my ears. I lift up my shirt. They're all over my belly and my back. We don't care about treatment. Next one is atopic dermatitis. You got to know. This is inherited. Genetics. Okay? It's common in babies. They'll have a rash. That's erythematous. It could have a little bit of exudate. Serous means it's clear. On the face, the chest, the shoulders. But in adults, the rash is going to be dry, scaly, and itchy. And in this one, they have thick, leathery patches called lichenification. Remember, I said you're going to want to know that. So atopic lichenification goes with that. Thick, leathery, dry skin. All right, so they'll have chronic inflammation from allergens. So IgE levels here elevated. Those of you that have kids that have this, you can't use any kind of soap on them, right? You got to have certain fabrics in your home. And quite honestly, we either use microfabrics here or leather. Extreme heat and cold can cause this. Well, you have it. Extreme heat and cold can make it worse, exacerbate the condition. And of course, they're at risk for infections because itchy means I'm scratching. And they don't just scratch with their fingernails. What else will they scratch with? What do you think? How about a hairbrush? How about a back scratcher? How about anything rough that they can get that little feel with that relieves? Okay, so here's your baby. Knees, elbows, wrists. We don't care about treatment. Next one is psoriasis. This is a chronic inflammatory skin disorder. It's genetic. Genetic. They're going to ask you about it. It's genetic psoriasis. The one before was inherited. This one is more genetic. Okay, both of them you inherit, by the way.
So eczema is inherited and psoriasis.
Eczema We didn't do eczema. We did
Oh,
psoriasis and we did atopic dermatitis. Atopic dermatitis, it said inherited, right? This one says genetic. All right, so pathophysiology here. This is going to pop out mostly in the teen years. We'll see remission and exacerbation. Abnormal T cell activation. I would know that. Psoriasis from abnormal T cell activation. So we get it genetically, abnormal T cell activation. Increase in cytokines. Remember, those cytokines can cause what? Inflammation. So because of the excessive growth of these keratinocytes, that's what that's saying there. Excessive proliferation means excessive growth. So we have all these keratinocytes developing, and that causes the dermis and the epidermis to be thicker. All right, so they'll have lesions that start as small red papules. So remember, papules are these little small raised areas, right? Now look at this psoriasis, okay? Silvery scales, dry, cracked skin, itching, burning, thick, pitted or ridged nails, painful joints. So they can develop something called psoriatic arthritis. These lesions, face, scalp, elbows, knees, with itching or burning. Okay, and it's plaque. Pemphigus. They like to ask about this. This is an autoimmune disorder. It comes in two forms, pemphigus vulgaris and pemphigus foliacus. And the severity can vary. Those are the two major forms. They'll just ask about pemphigus, okay? So here we have autoantibodies that disrupt the cohesion between the epidermal cells, and so they'll form these blisters. In pemphigus vulgaris, the most common form, so that's probably the one they'll ask you about, the epidermis separates above the basal area. The blisters form in the oral mucosa or on the scalp. So we'll see them in the mouth, on the scalp, and then they'll spread to the face and the trunk. And they become large, they rupture, they can leave large denuded areas of skin covered with crusts. If it's severe, it could become life-threatening. I don't know if you guys are familiar with Stevens-Johnson syndrome. If you're not, look it up. So it's autoimmune. The antibodies attack the skin and the mucous membranes, and it forms these blisters in the mouth, the face, the scalp, and spread to the skin. Now, this is not itchy, but it is very painful. If the blisters become bad enough in the mouth, it really can affect their ability to breathe. So, painful swollen blisters is common with this, okay? Scleroderma, another one they like to ask about. Here, it affects the organs. It is considered a skin disorder. They don't know the cause of it. So idiopathic, idiots don't know why, but we have an increase in the collagen. So we have these increased collagen deposits in the arterioles and the capillaries. and that reduces the amount of blood flow to the skin or the organs. The collagen deposits, inflammation, and fibrosis would decrease capillary networks developed in the skin. The skin is going to look hard, shiny, tight. Tomorrow we'll look at some pictures of this. Okay? And it doesn't move, especially in the face. Fingertips are narrowed and short. They can have Raynaud's. You guys are familiar with that? With Raynaud's, they have vasoconstriction, and they're at risk whenever they're in certain climates. They'll feel cold all the time. This is going to affect the circulation. They'll lose their facial expression as the skin tightens, and movement of their eyes and mouth can be affected here, but also other organs like the kidneys, the intestines, the lungs. There's a picture of it there. Scleroderma. Okay, look how shiny and tight the fingers are. Can you see that? And the face is starting to pull because it's so tight. My picture didn't populate for Dupuytren's contractures. I'm not sure why. Oh, maybe it populated on this one. All right. So this is a hand deformity that occurs when knots of the tissue form under the skin and pulls one of the fingers into a bent position. Mainly, it affects the two fingers that are farthest from the thumb. You might see that on the test question. So it's going to be the pinky and the ring finger there. So this is a slowly developing hand deformity that involves development of knots of tissue under the skin and on the palm of the hands.
And sorry, question. This is not associated with scleroderma, right? Is a
Yeah,
whole
they could develop this from the scleroderma.
Okay, thank you.
All right, skin infections. So I would know cellulitis especially, okay? But these are common on the skin. They can be caused by bacteria, viruses, fungi, opportunistic infections, some cut or abrasion on the skin. You can have bacterial infections. They're common. They can be caused by that resin in flora or by some wound or pruritic lesion developing there. This one I would know. Cellulitis, this is going to be infection of the dermis and subcutaneous tissue. So you need to know that part, and you also need to know what the cause is. So usually staph, remember staph is chains of clusters of balls, right? Clusters of balls, and streptococcus is those chain of balls. Usually in the lower trunks and the legs. Happens a lot in people that are immunocompromised. Now, as nurses, most of you should have seen this already in somebody. So if it happens in the leg, you'll notice that that leg is really red, swollen, hot, painful. Sometimes you can see red streaks in it, and sometimes you'll see it weeping, like a little bit of fluid. So again, signs of cellulitis, reddened area, swelling or edema, pain, red streaks. Furuncles. These are boils. And it's usually wherever there's a hair follicle. It's caused by staph. Most of the time, we'll see these on the face, the neck, the back. They can drain, purulent drainage. And we have to be careful because if we squeeze them to try to get the fluid out, it can spread. So these furuncles are going to be firm, red lesions. They're painful. They can develop into an abscess, produce a large amount of pus. And then carbuncles are a collection of furuncles that form a larger, more infected mass. So maybe you started with one ingrown hair, it became this furuncle, and now it's a whole area there, a whole large area there that's involved. In Patho, they also like to ask about this. This is common in babies and children. Also caused by staph, highly contagious. The lesions are going to be mostly on the face and transmission through close physical contact, usually sharing towels, things of that nature. In older children, it usually comes from staph, and it's spread by direct contact with the hands, eating utensils, equipment, or towels. Signs and symptoms are going to be small red vesicles that rapidly enlarge. The vesicles will eventually rupture and form this yellow-brown crust. Vesicles can develop around the primary site by touching the site and then touching other areas. And itching is common, and that also promotes the spread of infection because they scratch it and then they touch other areas. Acute necrotizing fasciitis. This is when we have a flesh-eating disease. It's caused by a mixture of aerobic and anaerobic. Aerobic means oxygen, anaerobic means without. And it usually happens right at the site of infection. We'll have inflammation, tissue necrosis, usually caused by Streptococcus group A. The bacteria will push out toxins that start to break down the fascia, the connective tissue. So they might have some sort of trauma or infection prior to developing this. This can also cause toxic shock syndrome. And some of these injuries can lead to gangrene. So usually they'll have an infected area that's really red and inflamed, painful. And it will rapidly increase in size, and then they'll have dermal gangrene apparent. With this, they'll have fever, tachycardia, low blood pressure, confusion. That's when it becomes systemic. So acute necrotizing fasciitis. Organ failure. This is another one they like to ask about, leprosy. Okay, leprosy is caused by a bacteria. That bacteria is Mycobacterium leprae. It is not highly contagious. Usually people come in contact for an extended period of time with the source. Clinical signs vary, but usually the skin, mucous membranes, peripheral nerves are affected. They'll have macules on the skin, a loss of feeling because of nerve damage. That can cause loss of limbs or other extremities. Tissue necrosis. And usually they need a biopsy to diagnose the bacteria. So it's caused by a bacteria. Herpes simplex. This is the gift that keeps on giving. So herpes simplex type 1, your cold sores. This is the most common type of cold sores or fever blisters. If you have it and you kiss your kid, they're going to get it. And guess what? Does the blister have to be present for you to give it? No. It can be in your saliva before the blister occurs or after the blister goes away, and you're still contagious. The primary infection can be asymptomatic, but the virus remains in the latent stage in the sensory nerve ganglion of the trigeminal nerve. I would know that. It can be reactivated and cause the lesion to reoccur. Now, what kind of things would cause the lesion to reoccur? Stress from the prom or getting married, a common cold, exposure to the sun, and then herpes simplex 2. This is genital herpes. Okay, both types will cause similar effects. Primary infection can be asymptomatic. Virus remains latent in the sensory nerve ganglia, and reoccurrence by stress, common cold, or sun exposure. It's spread by direct contact with fluid from the lesion. It can be spread before you see the lesions because it can be in that saliva. Potential complications are keratitis. This is the infection of the cornea. And this is because they touch the lesion, they don't wash their hands, and then they touch the eye. Herpetic whitlow. So this would be like in the finger. The finger becomes highly infected. I might have a picture of it on here. But like a dental person who either stuck their finger in somebody's mouth with that herpes in the saliva and their finger got nicked, or maybe they didn't wear gloves at all, or maybe they had a hole in the glove. Your book has a picture of it, if I don't have one. All right, so this is just showing you the process of how it spreads. Okay, the herpes simplex enters the cell. The virus is able to replicate. Remember, viruses have to replicate where?
In the host?
In the host cell of a human. Okay, viral replication causes necrosis. Those vesicles start to form. Then the virus will migrate because of your defense in your body, go back to the trigeminal nerve and stay latent, and the lesion will heal. And then as soon as something activates it again, the fever, blister, or whatever redevelops again. Varicose or warts, these are caused by HPV. There are many types of these viruses. Common plantar warts are caused by HPV types 1 through 4, and they can develop in kids or young adults, but they're harmless. Plantar warts, which happen usually on the soles of the feet, sometimes on the hands or the face. These spread by viral shedding from the surface skin. Genital warts, manifestations include the following: a papule, which is a solid raised lesion with distinct margins. It'll have a rough surface. It's usually white or tan in color, and there's usually multiple ones there. Now, this is the plantar warts. That's usually going to happen on the foot, on the sole of the foot. They can also develop fungal infections. Most are superficial. Fungal infections we diagnose by scraping the skin. Okay, and we look, a lot of these are associated with diabetes. They can happen systemically if the person is immunocompromised. So your diabetics, people with cancer, your AIDS people. Tinea, this is superficial skin infection, and it depends on where it happens on what we call it. So tinea capitis, cap, think about scalp. All right, so that's going to be on the head, okay? In school-age children, they can have redness. Tinea corpus, corpus is a body. So this is going to be on the body. So think about ringworm. All right, so that's your tinea capitis on the head and your tinea corpus, which is the ringworm. So signs and symptoms are going to be round erythematous rings of vesicles or papules with clear centers for the ringworm, and they're all over the body. They might have itching. It's usually going to happen wherever the body does not have hair. Tinea pedis, athlete's foot. This is going to be on the feet, usually the toes, and you can get this from the swimming pool, from the gym. It could be part of the normal flora if someone's immunocompromised and now they develop this opportunistically.
Red, come
Tinea,
out, we're here.
I'm sorry.
Okay, bye.
Take the tank out, please, puppy. Be
Please
careful.
put yourself on mute. Please put yourself on mute. Tinea unguium. This is infection of the nails, especially the toenails. So the toenails will look white and then brown. Then they start to thicken and crack. Is your athlete's foot. All right, or your tinea pedis. So again, we want to, avoid walking barefoot in certain areas. Here, the skin's going to become macerated and inflamed, especially between those toes. It's painful, it's itchy, and sometimes it'll make the feet stink. Scabies, this is where the little mites burrow into the epidermis. Now, some of you might have treated people with scabies, okay? And it won't go away. A lot of times they'll develop what we call Norwegian scabies. If you see somebody and you keep giving them that cream and it's not going away, ask your doctor about Norwegian scabies. They might need a pill to resolve this. Also, be very careful with your scabies creams because some of them you cannot use on people that have seizures. So that's why you got to know about your medication. Invasions, anyway, for this are by the mite Scarpodes scabia. We have to break the cycle of infection here. This is highly infectious, okay, in the social setting. And usually because they're sharing towels, they're in close contact with each other. The mite here is going to burrow into the epidermis and lay those eggs. All right, so there's your baby with the scabies on the back. Pediculosis, this is lice. So if it's corpus, remember that's body. So that's body lice. If it's capitis, it's in the head. So that's head lice. And if it's pubis, that's in the pubic area. All right, so these lice lay the eggs on the shaft of the hair. After hatching, they start to bite and suck the blood out so that they can produce more ova. That's your little bug there. All right, so they'll develop macules or papules that are highly itchy because of the saliva that the mite is introducing into the skin. And then excoriation because of the scratching. Adult lice are not visible. So if they ask you about it, you cannot see them. You can only see those little nits. Female lice lay the eggs on the hair shaft and cement the egg closely to the scalp. So it looks like this small white shell attached to the hair. Then after it hatches, it bites the human host and sucks the blood. And then that papule or that macule develops. Remember, adult lice, not visible. All right, skin tumors. This is the last of it. Keratosis. This is a benign lesion. Benign means that it's usually not going to be dangerous. It's going to stay where it's at. This can be associated with aging or skin damage. Seborrheic keratosis from growth of those basal cells. This can cause oval elevation that's smooth or rough, and it's usually found on the face or the upper trunk. Actinic keratosis, which is from exposure to the ultraviolet lights, and we'll usually see that more in fair-skinned people, and it'll look like a scaly patch. The actinic keratosis can develop into squamous cell carcinoma. So warning signs of cancer, I would know these: sores that don't heal, changes in size, shape, color, or texture of the lesion, new moles or odd-shaped lesions that develop, skin lesions that bleed repeatedly or ooze fluid, or they're itchy. We don't do treatment, so we don't have to worry about that. Next slide, okay? Squamous cell carcinoma, I would know this. This is painless malignant tumor of the epidermis. The lesions are mostly found on exposed areas of the skin, but they can be in the mouth. Typically, they're on the face, the neck, or the base of the tongue. There's excellent prognosis if we remove the lesion in a reasonable amount of time. If we don't, then it could be invasive. Squamous cell carcinoma comes from pre-malignant conditions like leukoplakia. Manifestations of this cancer include the following: development of a scaly, elevated red lesion, irregular border around the lesion, central ulceration of the lesion. These tumors grow slowly in all directions, invading the surrounding tissue, and then spreading to the lymph nodes. Malignant melanoma, this is the worst. Okay, this is highly metastatic, develops from melanocytes, and we see it on the rise. So this can come from a nevus mole. It's often multicolored. It changes shape, size, irregular borders. It can bleed. These will grow quickly and then metastasize into the lymph nodes and then to other organs, leading to a poor prognosis in most cases. These tumors usually develop on the chest or the back in men and the legs in women. However, common other sites are neck and face. So here's a picture of sun-exposed ear with squamous cell carcinoma. And then you want to look at the ABCDs of melanoma. I would know these. Melanoma is suspected in any nevus that shows a change in appearance, a change in border, a change in color, or an increase in diameter. Nevi that grow, change shape, color, size, texture, or bleed are suspected of malignant melanoma. They'll often look black, brown. Some might look pink, tan, or white with an irregular border. So you see the picture, none of them are perfectly round. They're all weird shaped. All right, that's malignant melanoma, which means a black tumor. This is the most dangerous type of skin cancer. It can grow quickly, spread to any organ. Melanoma comes from skin cells called melanocytes that produce melanin, the dark pigment that gives the skin its color. Most melanomas are black or brown, but some are pink, red, purple, or skin colored. This formerly rare type of skin cancer has come to prominence because of HIV. It's also endemic in Africa, where it affects younger people. In immunocompromised patients, Kaposi sarcoma is common and can affect the organs as well as the skin. Multiple skin lesions appear as purplish macules on the face, the scalp, the oral mucosa, and the lower extremities, so they can develop non-pruritic lesions, lesions that are non-painful, lesions that progress to form large, irregularly shaped apples or plaques or nodules. And again, they're going to be mostly seen in patients that are immunocompromised, and eventually they can become painful. So that's your Kaposi sarcoma. I would also note that. Questions?
No.
All right. I'll see y'all tomorrow night. That's it for this one.
Thank you.
Thank
All
you.
right.
Thank you.
Thank
What time
you.
is it
You're
tomorrow?
welcome.
Thanks.
Professor Loach,
Yes.
what time again tomorrow?
I think I set it for 7:45.
7:40. Okay, thank you.
All right. In the evening, 7:45 at night.
Got it. Okay. Have a good day.
All right.
Thank you.
You're welcome.
Do you know how many questions there's gonna be on the exam?
Should be 50.
Okay, thank you.